I think one of the key things that a supervisor does is make visible and make audible their practice wisdom. That's what a learner needs, and what this means is translating what's called tacit knowledge, those things we intuitively know when we're an expert in any topic. Speaking that out aloud, for example, it's called think aloud, where you actually speak what you know, because so often experts are going about what they do thinking that the learner is following along and understanding all the different points along the way, whereas there may be a whole lot of nuances that get missed out. So that's a key attribute of a supervisor, is to always be alert to those micro moments of teaching. And think aloud is a micro moment where instead of thinking you're too busy to teach, speaking out aloud what you're doing so that the learner can follow along. Now, of course, this has to be adapted. You know, if you've got patients and whānau around, you're going to be mindful of what you're saying compared to if you're privately one-on-one or in a simulated situation.
I think you do have to have that framework behind you, though, of what's expected. And that's part of what this project is to actually let people know what it's about. And I think it's been a little bit of a failing that we've had until recently, that it's been a little bit up to the supervisor to decide what is supervised. I think it needs to be a little bit stronger than that. I think there needs to be a little bit of direction and a framework behind it. But within that, I see my job as, well, it's partly preceptor, it's partly mentor, it's partly supervisor, it's partly just actually being a colleague. It's a collegial relationship more than anything else. So you need to have a blend of who your supervisors and mentors are through the year as a candidate to make sure that you've got a balance. You've got some technical academic supervision to keep you on track for that. And I see my role as being a clinical supervisor of checking those clinical aspects. I honestly wouldn't know whether they were a good nurse from a nursing perspective. That's for nurses to decide. I would never inhabit that space. I think I get a fair idea as the year goes on. I get a fair idea.
There are many names to describe people who are in the business of supporting learners to grow in their practice. And in a way, it doesn't so matter what your title is, whether you're a mentor or a supervisor or a preceptor. What matters is your philosophical approach to that process. And from my perspective, what supports those roles are a commitment to reflective practice, both our own reflective practice and that of the practitioner. So role modelling reflective practice, role modelling curiosity, and particularly important, role modelling those moments of uncertainty, role modelling where there is, for example, a clinical conundrum, an ethical issue.
To me, it's about a relationship, and what word you put around whether you're a preceptor, a mentor, or a supervisor, I don't think matters as much. For me as a doc, and that's the only position I can really speak from, it's a collegial relationship, and I have to be all of those. Sometimes I have to pick them up when they're down, when the process is just burdening them with 3 assignments due in the next 3 weeks. And where do we fit in the clinical teaching? Where do we fit in the clinical stuff? So you've got to be flexible and say, well, actually, let's do that in May when you haven't got so much on your plate. And some of it is saying you'll get through. My overall comment for people who would be thinking of doing this is that you have to have the breadth and think, what is my role at the moment? And sometimes it's actually ticking the boxes and saying, this candidate actually meets these competencies. Sometimes it's actually being alongside them and picking them up.
So we have to expose nurse practitioner candidates to different clinical environments. And what we are asking our supervisors to do is provide those candidates with the experience they need in practice. So real life situations around how we encounter patients, how do we engage in the process of differential diagnosis, deciding what's wrong with this person, How do we choose a treatment path? How do we choose a selection of drugs, whatever they might need in their practice? So the supervisor role is really quite important. So as part of our nurse practitioner candidates' educational experience, we need them to be exposed to really challenging circumstances that they won't have met as a registered nurse. And they're going to include things like being presented with patients with complex needs, complex differential diagnosis, not necessarily sure what's wrong with this person. And they're going to be doing that also in clinical settings which might be new to them. So it's a pretty alien environment for some of our nurse practitioner candidates, and the supervisor's role is integral to getting alongside that nurse practitioner candidate and helping them come to terms with these challenges and really have an effective learning experience.
So there might be weeks of little contact, 2 or 3, 4 weeks of little contact, and then there might be a lot of time of contact in 1 week. So it's the time to ensure the nurse is clear about the assessment of the patient, improving their assessment skills, improving their diagnostic skills and their prescribing and plan of care skills. Planning of care may or may not be prescribing, but making sure it fits what the patient's requirements are.
Depending on how your teaching style is and what you think is important, or what the area of practice that the student is involved in, there may be many opportunities to run clinical case reviews. You might be working in close confines with that particular supervisor on a daily basis, in which case you would be seeing cases throughout the day, and you might talk about them afterwards, or you might have a whole day of clinical practice where you saw 20 patients, and some of them you'll see by yourself with the supervisor, and others the supervisor will say, well, you can see that one and I'll see that one, we'll meet afterwards and you can tell me what your findings were.
Going out and working with nurses and watching them work gives you an idea, are they getting an adequate history? Have they read all the other documentation that is in the patient's case file? Are they up to date with current tests that have come, results of current tests that are coming in? So you're checking that none of the processes are being missed. And as you interview the patient and get their history, you're also ensuring that the nurse is picking up the correct cues and then understands their cues, and are they asking the right questions following that little bit of information. So it gives you a heck of a lot of information. Are they getting the right information to then make the right diagnosis? The other thing that's important is watching their physical examination skills, because checking that they're doing it properly. Listen to the health history that they collect to check that it's thorough enough. You need to watch the person do their physical examination to check that their techniques are correct. You need to watch the interpretation of diagnostic tests to see if they're interpreting them correctly, and ensuring that they're getting enough information to make the right diagnoses. From that, working with them to see what their rationale is like for their plan of care, whether it's prescribing or non-prescribing. The nurse themselves, when they come into an intern program, they haven't really got an understanding of the difference between registered nurse and nurse practitioner practice. And so if the nurse hasn't got a very good understanding and is starting to think at RNs, and the doctor has never worked with a nurse practitioner, it's very difficult to have that understanding. So it's going back to those competencies, and that's the standard expected. It's not just a very good nurse, it is a nurse practitioner that we want and that you're developing towards. So go back to the competencies, and they will guide you on the level of behaviours and knowledge that is required. If they're doing a health history and they have got some information and hadn't followed up the questioning of it, I just ask the patient myself. So in fact, when I'm watching a nurse do the assessment, I'm not standing by the wall watching, I'm actually part of the team with the nurse. So I quite comfortably just will step in and ask that question and explore that question. If they missed any questions, the health history is not thorough, I will just step in and ask it. So I do that because you can't do it after, because you've missed your patient encounter, and the patient can have inferior care if it's missed. During the physical examination, for example, simple thing like chest auscultation, if the stethoscope's been put in the wrong place, I will say then, oh, can you move your stethoscope to these areas? And I don't mind doing it in front of the patient. The patient knows that this person is learning, so that is not an issue. And most patients are used to people learning, and they think that's a good thing. So you can sort out technique.
So giving feedback is an area that many people find challenging, and there are some ideas that are really helpful with giving feedback. One of the things that can be really terrific is when you're first setting up the relationship, talking about how it's going to be, how you're going to work together, address the issue of giving feedback then. How do you like to receive feedback? How have you received feedback in the past? What works for you, what doesn't work for you? Making it clear that regular feedback will be part of the process. I think if feedback's a habit and both people are expecting it, then it's so much easier at the end of every session. You know, gosh, I really thought that when you did that, I can see you coming along so well. And an area that I'd want you to pay attention to as a development area is this area here. You'll notice there too, I'm combining motivational and developmental feedback. Really, really important to tell people what goes well, and it's really important to describe it in behavioural terms. Now that can be a communication behaviour. I noticed the skill you had in that palliative care situation talking with that family, or it can be technical description. When you undertook that particular procedure, I noticed the detailed attention you gave to XYZ. That is quite different from saying, you're fabulous. You got to knock them dead. You know, the person, that's sort of a warm fuzzy, but it sort of falls away and the person doesn't quite know what you've noticed. There's several other principles about giving feedback, and this is a principle about timing, that we either give feedback as close to the incident as possible, and if it's not possible then, we give it as close to in front of the next time the person will perform that activity.